The COVID-19 outbreak was declared a pandemic by the World Health Organization in March. 3 months later, we know from research, surveys, news stories, social media, and first person accounts, the pandemic made and still makes unprecedented demands on already overstretched healthcare systems and their care teams. Doctors and nurses and many, many others on the front lines in hospitals have been responding to very sick patients because of the virus. They've often been sole support and witnesses to tremendous loss of life. They face constant challenges around personal protective equipment, PPE, and experienced anxiety about their own or their family's health. And they've worked long hours in environments filled with purpose, but also endless stress. So, what's the upshot of all this? Well, it's complicated and maybe will grow more so as attention and gratitude inevitably shifts away from frontline caregivers responding to a pandemic to the reopening of other healthcare services and the reopening of businesses and society overall. Is there a danger of a disconnect opening up between weary clinicians and caregivers still contending with patients dealing with a contagious virus and all those eager to resume their lives, whatever that means specifically? So, two people who know a lot about our topic are with us as panelists, and lucky you and lucky us. Tyler Norris is CEO of WellBeing Trust, and Nicole Laurie is strategic advisor to the CEO of Coalition for Epidemic Preparedness Innovations. And of course, we welcome back IHI's Don Berwick and Derek Feely. They've been our regular expert panelists on these virtual learning hours. So, hello to everyone. Hello to the panelists. Hello to our audience. As usual, you're going to hear from our panel for about 30 minutes, and then we'll turn to Q&A and discussion. You're welcome to chat in at any time during the hour. We'll get to your questions and comments in the second half of the program. So, Don Berwick, let's start with you for some framing. As you know, everyone has wanted to celebrate the heroics of people on the front lines during this pandemic, and that's happened in a variety of ways, very public ways, all over the world. And the appreciation has been quite genuine. But I'm wondering, have we missed some things in all the clapping? Thanks, Don.
Thank you, Madge, and thanks, Tyler and Nikki, for joining us. I'll say Tyler, longstanding colleague and friend, and the same to Nikki, who served as Assistant Secretary for Preparedness and Response in the Obama administration when I was at CMS. It's a delight to have them here. I will answer the question, Madge, but I can't begin without just a brief acknowledgement of what's going on in our country right now in our streets in the wake of the George Floyd tragedy, murder, and the chronic problems of exclusion and racism and despair that really represents. It is connected to our topic today, deeply connected, and we'll come back to that. But we just, I think, on everyone's mind is what's on my mind, which is how can we get this country back to the compassion and justice that it has long claimed to embrace but not delivered on. Let's go to the question, though, that you're asking about the heroics of the healthcare workforce and the burden on them. It's very personal to me. My daughter, Jessica, is a hospitalist at a Boston area hospital, and she is at work hard day after day in the week. She returns home to her two children, a 10-year-old and a 3-year-old, and her husband. And I watched Jessica cope with both kinds of stress in her life. The stress of the care itself, worrying about her patients, worrying about exposures, watching a very, very bad disease play out inequitably, by the way. Almost all of Jessica's patients in the COVID epidemic are Black and brown, although that's not true of the demography of the place she works. So she sees it up close, and I hear about it every day with anguish in her voice and on her face. And then she comes home to a stressed family, a wonderful family, everyone trying to cope, but a pre-adolescent who's isolated in his house, a 3-year-old who misses her mom, a husband who's been dealing with his work and childcare and the threat of COVID being introduced into the household. It's ever present in her life, and she's doing okay. But she'd be the first to say that this is not easy. And look at the lucky circumstances she's in with her condition, her wealth, her social systems, her connectivity, the neighborhood she's in. She has a lot of advantages and still feels the stress. Imagine what's going on with the healthcare workforce membership that's not like that. What about the nurses, aides, and the housekeepers of the hospital that she absolutely depends on, and who have less resilience in their bank accounts and their social conditions than she's lucky to have. We've got to attend to this. And yes, I loved seeing the clapping in the streets. I moved to tears when I watched the windows open in Milan or New York, celebrating this workforce. Um, but you know, clapping is a lot easier than fixing the social conditions that are creating and aggravating the stresses of so many people who work in healthcare. Not to mention, of course, the populations they serve. I don't want to sound like a grouch, but when we clap, we need to mean it, which means structural changes, deep changes in the social conditions in our country and other countries to support real safety and opportunity for everyone. So we're going to hear from real experts, Tyler and Nikki, and I'll special note to Tyler to thank the WellBeing Trust for the support for this ongoing series. Now, this could not be more timely, and the support of the WellBeing Trust is much appreciated. And Nikki, I know how busy you are. Thanks for being with us. So let me back over to you, Madge. Thank you very much.
All right. Thanks, Don. Appreciate it. So, Tyler Norris, I understand that you're concerned about a second curve, as it were, of health issues related to COVID-19, in this case, related to mental health. So, tell us whose mental health is at risk and what types of problems and issues are you concerned about and feel that will need addressing? Thanks.
Madge, thank you and the IHI team and Don and all for including WellBeing Trust in this session. And WellBeing Trust is pleased to be partnering with you in this series going forward. So thrilled. And Don, I think before I address Madge's question, I want to pick up right where you left off. There will be no path to health and well-being in this nation without addressing equity and social justice. That not only what's happening on the streets, as we learned from Dr. King, that riots are the language of the unheard. And in many ways, this is a referendum on the economic and social policies in the country that are leading to pervasive health disparities and inequities and systems failure that are being revealed and unmasked by COVID. So the fundamental changes in meaningful opportunity and the conditions for well-being in the first place must be addressed if, in fact, we're going to have a measurable improvement in population health. And I hope that this moment really helps us hone in on that in a very significant way. So what is the second curve? Who is it? And what needs to happen? We're talking about the rise in mental health, substance use disorders, triggered by the economic and social dislocation and fallout. We have 40 million Americans that have applied for unemployment during this time. This means higher rates of anxiety, depression, and suicidal ideation. It means higher rates of the deaths of despair, deaths from alcohol, opioids, and suicide, as we wrote about in our Pain in the Nation report, with evidence-based strategies to address them. But underneath those deaths of despair, as we know, is hopelessness and loneliness and isolation, a lack of economic opportunity. And as we are seeing, the calls to end the racism in our country that diminish people's opportunity to have the full potential of their lives manifest, right? But there's a whole nother layer of that, and I think Nikki's going to talk about it too, which is rates of child abuse and elder abuse and intimate partner violence that are kind of layered on top of that, given sheltering in place, where children are not able to be seen by their coaches or teachers who might be keeping an eye on what's happening, and elders don't have much opportunity right now, or those who are abused find themselves unable to go someplace away from their abuser. These are very real issues. The rates are rising, as we're seeing from Crisis Text Line and others around, and as we've seen in Gallup surveys, where typical rates of anxiety and depression are being shown that half of us are now showing clinical degrees of mild to moderate anxiety and depression. So another whole layer of this is rising social needs. food insecurity, housing insecurity. But I think as we talk about the second curve of mental health and substance use and forms of harm from sheltering in place, we're going to need to think about successive curves, really, of layering on crisis upon crisis. The curve of the virus, the curve that I've been talking about of mental health and substance use disorders, but then another whole curve of chronic disease that is because of the disruptions of people's healthy patterns of eating healthier, moving more, physical activity, nature, and social isolation, what Vivek Murthy has written about so beautifully in his book Together. We are bereft when we are isolated from each other, and we're beginning to see that express itself in ways that, according to the report we did with the Robert Graham Center, that the deaths based on 8 different models may reach almost 80,000 additional deaths of despair. Secondly, who are we talking about? So layering of crises. Hurricane season is approaching. Fire season is approaching here in Northern California. And the streets like mine in Oakland are filled with layers and layers of issues that we're going to be facing and caregivers are facing. Who is this? To your question, it is all of us, especially Black America, Brown America, and marginalized people everywhere, whether that's rural, LGBTQIA, the young, the old, and essential workers, right? We're speaking about, and Don, I appreciate you bringing that up, doctors, nurses, but how about those essential workers of the moment who are in low prestige jobs, who are experiencing a very significant respect gap, be they caregivers of different forms, care aides, clerks, and cleaners, and others who do not have that power equation that many others do, where they are experiencing physical distancing as a privilege. I think that's a very real issue. Thirdly, your question, what needs to be addressed? Just to back up a minute, many of you know WellBeing Trust is an impact philanthropy born in Providence Health with a mission to advance the mental, social, and spiritual health of the country. Our goal to save 100,000 lives from death to despair, and our model is building a social movement, distributed action. So in the framework for excellence, next slide, that we have built, it is becoming a consensus platform for action in this country. We're addressing on the left side the vital community conditions for well-being in the first place that Don was addressing. And frankly, how do we get the care right? Integrated whole person care, no wrong door, clinical community integrated. And secondly, advancing the public policy and incentive structures to get it paid for. But the key for the vital conditions is it's not just throwing grants and tinkering at the margin and doing good things. We need to get moving from doing good things to being accountable for outcomes in our communities. That is a muscle that healthcare has to be able to build to have a standard of quality, mean that we are delivering those vital conditions. And then finally, in my opening piece, just go to the next slide, that as WellBeing Trust is advancing strategies to get the care right, advancing public policy to get it paid for through our work with Healing the Nation, we're investing in the infrastructure for the mental health and well-being movement to assure what needs to be in place to have an impact. We reverse engineered social movement theory, and we're investing in communication strategies to get the narratives right, measurement systems like the WIN measures that roll up to thriving scores to be able to measure and track what's working, public policy that is focused with policy engines to advance healthy policy at the state and federal level, economic engines to bring new dollars into mental health, leadership structures that can act, standards of quality, like I just discussed, of what integrated whole person dose sufficient care looks like that will have a measurable impact on population health, and meaningful pathways for people to engage. That's the kind of agenda that it will take to have a meaningful impact on outcomes in the country, not only for caregivers, which we'll come back to, but for all Americans in this time.
Tyler, just for one more minute, I want to go back to some of your themes, and just so I can kind of help sort of thread the needle through the show, do you feel that the caregiver circumstance right now requires something different, something more unique? Is there something we're still not understanding about some of these jobs in these crises situations?
I think that first of all, we need to focus on our frontline caregivers who are selflessly serving and putting themselves in harm's way every day. And not only those doctors and nurses on the front line, but as I was describing before, those in low status, low skill, low prestige jobs, whether they are in our food supply chains or transportation networks or elsewhere. Many of those individuals we are calling essential workers now, but they are low wage, without benefits, and without others. So, yes, we need to focus on our doctors and physicians. And later in the program, I want to talk about why we're investing with IHI in this program and what can we be doing for frontline caregivers. But at some level, we are all caregivers right now, and particularly those essential workers of lower prestige are those that I think we are most significantly missing in this, who have low power, who predominantly black and brown, and are the very people, as Don and others are talking about, that are suffering most mightily from the virus itself, because physical distancing is in fact a privilege for many of us. And that's part of the mindset that we have to have. Yes, our frontline caregivers, but also our police officers, fire people, EMTs, and other first responders, care navigators on the front line. Everyone.
Okay.
Thank you.
All right. No, it's great. It's a important, broad, and very meaningful context. So thanks. Nikki, Nicole Laurie, turning to you. So you've been in and around all these issues for quite some time. Apparently, you've said every major disaster is accompanied by a behavioral health crisis. And perhaps as Assistant Secretary for Preparedness and Response for HHS, have witnessed that firsthand. So I think partly what you could help us understand, what makes COVID-19 different or perhaps similar to hurricanes, terrorism, and other crises? Thanks a lot.
Well, thanks for the question. And let me also just say thank you for the opportunity to be here. And, as we are talking about equity, in the first case, just a reminder that every major disaster, whether it's a pandemic, whether it's a hurricane, whether it's a flood, has unequal impacts. And every single one of those is an equity issue and who it impacts and who recovers from that. And so one of the tenets that I've always espoused in managing disasters is, if you use the 80-20 rule, probably 80% of what you need to do is the same, regardless of the situation. And in this case, every major disaster is, first of all, accompanied by epidemics of fear and by a huge behavioral health crisis. The question is, what do we do about it, right? But the population health impacts, as Tyler was talking about, are almost always related to displacement, anxiety and depression, substance abuse, whether it's new or recurrent or relapse, and domestic violence and child abuse, for sure. And in every one of these, what you see is the whole population is affected, but that the first responders and the healthcare workers are in some sense disproportionately affected, partly because they have this culture around them that they have to be tough. They have to self-contain it all. They can't let it out. Their job is to take care of everybody else, not necessarily also to take care of themselves. And as I used to remind people, when I was assistant secretary, you can't take care of the country unless you take care of yourself. You can't take care of others unless you need to do that. But for me, I first became aware of a lot of this actually during the Deepwater Horizon oil spill. And remember, that was the same region of the country that had been affected by Katrina and then a whole other series of hurricanes with repeated cycles of trauma, dislocation, unemployment, always disproportionately affecting minority populations. And what I learned early on is that during the Exxon Valdez oil spill in Alaska, 40% of the population impacted by this bill had long-term impacts related to um, DSM diagnoses of anxiety and depression. And my question was, okay, if you can predict that coming, what do you do about it? The healthcare system, as we all know, typically waits till people get sick and then worries about it down the road. So what do we do about it? Interestingly, one of the things that we set up early on was this disaster distress line, at that time funded by BP. That now has become this disaster text line that is now embedded into our day-to-day system for how we handle this, and is receiving thousands upon thousands of texts, which is great. We learned about population approaches where you train lay people in the community to think about how to administer psychological first aid, recognize people in distress, help them, but always with this idea of shifting the curve to the left. And so, what I would say about the science of prevention here is it's really incomplete and needs some work. And if you want to say never let a disaster go to waste, this is the opportunity to figure it out. So, what does make a pandemic different from a hurricane or a flood in this? And I think some of these things are really obvious, and we've talked about them already. But obviously, the global scope, there's nowhere you can go to escape. You can't evacuate to someplace else that's better, right? You can't, in these circumstances, go to be with family and friends because you might risk getting more infected. And then there's this concomitant societal disruption that not only affects a small geographic area, but is affecting our whole country or the whole world. Most of the disasters that we've dealt with in other circumstances are also time limited. A hurricane blows through, a tornado blows through, an earthquake happens, whatever it is, even a terrorism event. But then the acute situation is over. We have no idea when this thing is going to be quote unquote over. And so the time unlimited nature of it makes it very unsettling and very hard for people psychologically to say, here's a date on my calendar when it's going to be over. Maybe they did that with phase one reopening, which is a little dangerous. But here's a date on a calendar when it's going to be over, and you can't get there yet. I think we've talked about some of the risks. Many of them are unknown, both short and long term, right? And their risk to people, to the individual caregiver, their risk to families, their risk to society and to your future patients. And frankly, we do not yet know what the long-term sequelae of this disease are. And we are only starting to hear about a subsegment of the population that has very, very long-term sequelae, and we don't know whether and how they will recover. Something else that has characterized this event in many countries, not all, but many, including the US, has been really a failure and a betrayal by government and trusted institutions for healthcare workers. And so healthcare workers understand they've got a duty to care. They're doctors and nurses and others very much in this profession because of that duty to care. But there is a compact, and sometimes it's unspoken and sometimes it is not, that this institution you work for and in is going to protect you in some way, is going to take care of you. And there is an unspoken compact between people and their government that when the chips are down, government steps in and protects and cares for you. And in this case, many of the institutions in which healthcare workers work and government has failed the public and has failed healthcare workers. It hasn't been able to provide basic protection even in the form of PPE. It hasn't been able to provide adequate staff to expel people from working long hours. It hasn't been able to provide the psychosocial and emotional support. It often hasn't been able to provide the kinds of things like childcare that happen in other emergencies because of fear of infection. And it hasn't been able to guarantee you at the end of the day, after working as hard as you've worked, that you have a job, because the healthcare system itself has been so disproportionately impacted by the economic crisis. And so what you see is many healthcare workers being laid off, being furloughed, being out of work, even after they have taken these disproportionate risks. And so I think this failure and betrayal psychologically is going to have really devastating impacts down the road, and something I think that we need to think about as institutions think about how do they respond to this. And then along with that are what I would call these repeated assaults on professionalism. So first of all, as a health professional, you often feel kind of empowered to help. And in many of these circumstances, you can't. We hear repeatedly from healthcare workers of all different kinds that there's nothing I could do, but I could provide comfort. And so to help reframe the helplessness in terms of what people actually can do to help, I think is really important. The exhaustion is profound. And then we've certainly talked about the fact that this pandemic is having really disproportionate impacts on Black and Brown populations in particular, and on low-income populations. But we're also hearing a ton about racism and stigma toward healthcare workers who themselves are Black and Brown, who themselves are Asians. People don't want to be taken care of an Asian physician because they think this is where this is coming from. The racism and stigma toward healthcare workers, which frankly has been there all the time, has become a little unmasked for an awful lot of people. You are bringing disease into my hospital, into my institution, into whatever, because you're Black and Brown. And I feel as though this is something that is unspoken, it is unaddressed. It's not yet a very explicit part of how it is that we try to help healthcare workers cope, and yet it seems to be everywhere.
Thank you, Nikki. We have a tall, deep, and wide agenda, and that's important. I mean, we have to know what it is we're contending with in so many ways. So, Tyler, thank you, Nikki. And Tyler, we're going to shift us a bit towards prevention. I mean, we got it's all laid out there on this slide. These, pretty big issues here. How does one start to get a handle on anticipation and prevention? Do you call these things by that name? Do you speak to frontline caregivers and let's talk about the helplessness you felt, for example? Thanks.
Oh, first of all, really, Nikki, what a gorgeous framing of the challenges that we're facing and the failure and betrayal. I think the language that we're describing of COVID unmasking systems failure and inequity is spot on. But as W.E.B. Du Bois said famously, turn of the last century, that a system can't fail those that it was not intended to serve. So I think we have to ask the question, have we actually, from a prevention perspective, have we actually built the conditions in our community that give rise to human flourishing and well-being in the first place? And it's not surprising that our frontline caregivers, many of whom are only essential in the moment. And again, I want to acknowledge the doctors and the nurses, but that part of the challenge is that we haven't built the communities that have the support for people's human flourishing in the first place. And every single one of our hospital systems in this country, the second part of their mission statement runs like, and to improve the health of the communities we serve. I think that we should know that that every system is designed to get the outcomes that it gets, right? We see what's occurring, and that's the system that we've built. So we could talk more about prevention, but we could have a conversation as well about what is the role of the health sector, not only through its own resources, but in leadership in this country to make sure that those conditions for well-being are in place in the first place. First 1,000 days of life, food security, housing security, meaningful, effective education systems that we know give people a life trajectory. Because later, when we come around and say, well, look at the vulnerable folks, and what should we have done? Let's get more protective equipment. Of course we need to do that. Of course we need to do that. But we have a much larger moral issue that Don was talking about at the summit at the end of last year, of a moral failing on the determinants of health, about how we're actually making investments. And that is the role of the health sector to lead in this area. on the moral cause for what it means for a country to invest in the vital conditions for intergenerational well-being in the first place. So I would love to have a conversation about what do we do to prepare more for the protection and care of the healthcare workforce, and we're investing in this whole series for that purpose. But one of the reasons I wanted to join personally this morning is to remind us that this is far deeper than caregivers. It is all of us. And if you want to take a look at the mental health issues, we say 1 in 4 people, 1 in 5. It's 1 in 1. We are all vulnerable. And if we're not suffering from one of those conditions where someone immediate in our life is, mental health and well-being and being a caregiver is about all of us. And yes, let's look at those frontline providers, but let's take a look at the society within which those caregivers live.
So, Tyler, can I challenge you for just a minute on this?
Please,
because I
Nikki,
agree with you entirely and wholeheartedly. And most of us on this panel and call have spent our entire professional careers working on this issue. And we all know that we can't erase this with clapping. We can't erase it in a month or a year or with recovery. But we've been having this conversation for many years. And as a good friend of mine says, we keep doing the same thing, only louder. Louder doesn't work. I think most of us recognize that we are at a crucial and fundamental pivot point in our society now, and that it's a pretty precarious pivot point. But what is it that we're really going to do differently to address the kinds of social conditions and the underlying structural factors that impact health and well-being and thriving and all of that? I totally agree with you, but we need a roadmap to something fundamentally different.
Well, I couldn't agree more, and I want to respect the timing and others' voices here. But first of all, I believe that you are right. This is a legacy moment for the United States of America. We can't change the future we've inherited, but we can sure as heck change the future that we pass on to the next generation. This must be a galvanizing moment. The leadership of the healthcare sector in this United States is right now watching behavioral health providers close. Lights getting turned off, people not getting paid, and that's a leadership issue. Yeah, we got to look at our frontline health systems, but what are we doing for the systems of care more broadly in our community? And I think that the question you've asked must be a koan, must be a rock and a pebble in our shoe for the leadership of the healthcare sector, given the role it plays in this country. What is the role we are playing in shaping a country that invests in the conditions for health and well-being in the first place, to living up to our social justice missions, to improve the health of the communities we serve, and to move from tinkering to being accountable for outcomes, to owning the problem and owning the solution? And I think that's a leadership question that this moment does call us to. And as we advance a blueprint for equitable recovery and resilience in this country in partnership with the CDC and the CDC Foundation, there is a massive role for the healthcare sector to help both respond to recovery now, but the kind of resilience investments over time.
Okay, what I'm going to do, always it's terrific that we're sort of putting all this out here. And one of the great things is there's this program today. It will be archived for everyone's availability. There will be then another one at the end of June, and then 5 more that I can imagine Jess Perlow, who heads up a lot of IHI's work in this space, Joy and Work. We're going to see kind of how we're going to work through, I think, a lot of the issues that Nikki's laid out, Tyler's laid out, Don did earlier. Now we're going to hear, before we go to chat in earnest, from IHI's president and CEO, Derek Feely. I don't know if your ears were burning when they were talking about leaders and leadership, Derek, but I think IHI has sort of put its mark in some of this space with work on Joy and Work, and you dared to write an essay in the midst of the pandemic, reminding people of why it did matter in a pandemic. So pick up on some of the themes here, Derek, and some of your reflections on what our task is with all that we're hearing about. Thanks.
Well, thank you, Madge. And so I think such was the quality of the contributions of Tyler and Nikki, I actually don't have too much to add. And so what I'll try to do instead is just pick up a few points that they made and perhaps accentuate them. So firstly, Nikki's challenge, I think, to all of us was, well, let's act. This is not a time for louder voices, it's a time for action. And we agree with that. The genesis of the partnership between IHI and WellBeing Trust was to move us to action. And these programs are one way that we're trying to build momentum and energy for that action. But we plan to have something that health systems can implement. And indeed, we have some health systems, including Providence, who are already saying we will implement. So that gives me hope that we can, in due course, respond to Nikki's challenge and move to action. Second, I think both Tyler and Nikki have stressed the importance of a systems-based response. That we need to, that we can't see this as a simple problem that has a silver bullet solution. This is going to take systems mobilized in a different kind of way. That's what the framework for excellence that Tyler showed us earlier is all about. And it's what this framework that we're showing on the screen now, which is IHI's Joy and Work framework, also recognizes that there are a set of things that senior leaders need to do, including paying attention to meaning and purpose and creating a sense of psychological safety that will help create an environment where people can feel a stronger sense of mental well-being. There's also some things that we need to do in teams, including building camaraderie and teamwork in those teams. And there are some things that individuals can do to bolster their own resilience. I think what we see too often that we place all of the responsibility for dealing with these challenges on the individuals themselves. I call it sometimes the pull yourself together school of thinking. And that is not going to work for us, given the magnitude of this challenge, given the kind of things that Nikki and Tyler have so eloquently set out for us. And remember that even before COVID-19, our healthcare workforce was feeling challenged. We had suicide rates amongst physicians that were twice the level in the rest of the population. We had a quarter of ICU nurses displaying symptoms of PTSD. You know, we were building on shaky foundations, and now we have the possible second wave that follows COVID-19 to deal with. So yeah, I think that's what I'm hearing and taking from Nikki and Tyler's contributions, Madge. That firstly, we need to move to action. And second, that action needs to be systemic. It will take contributions from senior leaders, from policymakers, from core leaders and managers, from every single one of us. And we need to look below the surface. We need to see the part of the iceberg that is currently hidden from us, because there's a set of patterns and behaviors and structures and policy and economic levers and mental models that we're going to have to address if we're going to have impact on the events that are visible. But thank you, Nikki and Tyler, for giving us such powerful prompts as to where we begin this journey towards action.
Thank you, Derek. I want to also just invite Don Berwick, if you want to jump back in at any time, Don, please do. I mean, I think we know jumping into these topics, and we're going to be at it, our experts and guests, and Jess Perlow and Don and Derek, over a series of shows to sort of turn the prism around about what are we talking about. And I think the hope will be that when we're talking about the workforce at all levels, as Tyler was reminding us of who we mean when we're talking about frontline caregivers, et cetera, really getting to the whole extent of that. And while we're at it, we can definitely go beyond the hospital into other settings of care and home aides, et cetera, and people in nursing homes. But I think if we stick with this idea of we as us and us as them, and that we've got a whole big picture, as we talk about the workforce, people who are sometimes at the sharp end of trying to do the best thing, let's say at a time of crisis, perhaps we can start learning for all of us. And I guess one of the issues, which I'd invite anyone in the audience, I think that IHI has been trying to break through, is this idea that you don't talk about what's bothering you at work, or you only talk about it to certain people, and it's very isolating. And I'd be curious whether any of the organizations or any institutions that are at least coming out of the worst of the surge and pandemic are finding ways to help surface what people have felt that they've been through. I suspect, Derek, it's something that we'll be looking for. And just too, as the Joy in Work learning community goes on. And that's part of what we're trying to figure out, I think, at IHI, is what are those models. So I think we're all maybe a little bit stumbling. I wanted to, or I'm stumbling. I'm sorry, I shouldn't speak for anyone else. I'm cognizant that it's 10:42, and I promised Nikki Laurie we would let her go at 10:45 because she's a busy lady and in hot demand. Nikki, is there something you want to say just before you go? I think we always get very tied up around this issue of who's included and where do we start and whose problems maybe matter or the worst. Any thoughts on that or anything you'd like to say?
Well, thanks. And maybe just a couple thoughts as I'm listening to this conversation. And, I'm hearkening back to this little email exchange that we had getting ready for this about, are we focusing on, healthcare workers, writ large, or the population, or our patients, or the people we serve? And, for so many healthcare workers, their own sense of identity and satisfaction and the way in which they work is so inextricably linked to how their patients are doing that I don't think necessarily that we can completely separate them. But that part of my point, I think, about a prevention approach to this, in part, and yes, prevention, including addressing all the social and societal determinants, is in some sense, and when we talk particularly about mental health or behavioral health, less about well-being, we still have this incredibly medicalized model of this. And we're talking about the whole population of this country and beyond right now needing some help and some care. And it's especially hard to get that, when people can't congregate and when people see the divisions between people more than the connections between people. But I think that in that carefully disguised golden opportunity, there are some golden opportunities to really think about. We can call it prevention, we can call it all sorts of things, but we got to do it. And we can't just wait till our patients, our caregivers, anybody else gets sick, die from despair, can't work, all of those things. There has to be, getting back to some of the origins of what I think this session was going to be about, a different model. And totally agree with Tyler and everybody else about just addressing the underlying social conditions. Those are going to take years and generations, and we keep working on them. But I feel like we need a 1 month strategy, a 3 month strategy, a 1 year strategy as we look at coming out of this, and underlying all that are all the other issues that we are talking about. Yes, and there's a 5 month strategy that includes an election. Um, but but that alone isn't going to solve the problem either. Let's face
Yeah,
it.
right, right.
So I would really love to see us think about how it is that we protect people from getting sicker, help them get better, and what it is that our learning health systems, and I think our professional societies are in this too, and a number of professional societies really want to step up and to think about, can we organize sort of a blanket or safety net for the healthcare workers in this country by pulling together the resources of health systems, learning health systems, and professional societies. What does that look like? I think it needs to be organized. I think it needs to be structured. It can't be catch as catch can. But I'm seriously talking about needing a national structure and a national movement. I believe it's something our federal government should be doing. It's not. So why don't the rest of us just step up? One of the great things about this whole thing we've been going through is we've seen leadership in all kinds of places we didn't expect to find it. And I think the leadership to do this is here, it's on this call, it's around our country in places that we don't expect to find it. But let's get it organized.
Nikki, thank you very much for your time. We hope we'll be able to take advantage of your wisdom and expertise going forward through this process. So thank you very much.
Thanks.
Okay, great. I'm going to just let Don Berwick, jump back in here. He has some thoughts, and I'm sure he's listening and looking at the chat too. Don.
I am so glad we have a number of sessions to deal with this match. It's not going to be covered. And there's a rather poignant chat from Lisa Davis in the series. She says, "Please give me something concrete." And I get it. I mean, I'm as overwhelmed as anyone on this call by the eloquence of Tyler and Nikki in describing how big this problem is, and every avenue we go down leads to more. I'll give you 4 concrete things that are on my mind, and I welcome Tyler and Derek and anyone else in the chat, as you say. And I think over time we should collect concrete things in response to Lisa and be able to offer them. First is at the organizational level, income of healthcare workers should be addressed. The minimum wage is not a sufficient wage to achieve healthy living in this country. And we have seen in the IHI Leadership Alliance, some organizations step up and re-examine their wage structures and say, for people at the bottom of that scale, we're going to do better for you. The great British epidemiologist Jerry Morris outlined years ago something what he called the minimum income for healthy living. Check it out. And could I challenge healthcare organizations to adopt a minimum income for healthy living as the wage structure? Forget the minimum wage. It has nothing to do with what's needed. Second is the benefit structure overall. We have literally millions of healthcare workers who do not have health insurance. That's got to stop. And I think we should need a commitment from the healthcare industry saying every healthcare worker has health insurance, even in a country that's not yet committed to that politically. We got to find a way to do it. A third, Nikki mentioned it, is voting. A sense of disempowerment is a threshold to despair. People need to take power back. That happens in the ballot box. We are facing an election. I'm not telling people how to vote, but I'm saying vote. And I would like to see a commitment in this industry to say every healthcare worker votes, and anything organizations can do to support that and make sure people get out into that ballot box is the beginning of some of the change we need. Finally, there's a special thing I've repeated through several years now. I know this sounds off center. Maybe Tyler will comment on it, but it has to do with the criminal justice system. It is the biggest embarrassment in American social policy today that we have 2.3 million people incarcerated, mostly Black and brown, at 7 or 8 times the rate of whites, mostly with substance abuse or mental health disorder, 70%. I urge an engagement between the healthcare system as a total industry and every single organization, every single community with the criminal justice structures in their community, and let's get this fixed. Why is that related to despair? Because the antidote to despair in part is self-efficacy. It's a sense I can affect things. And if we can get involved with the conditions as a community that we're talking about, I think it'll help. You're always happier taking action than being the victim. And I think So I nominate those four to Lisa, but there'll be better ideas here. And I'm sorry for carrying on this, Madge.
Not at all. We expect, yeah, Derek often has three. You sometimes have four or six, and we can all do kind of multi-voting, and they're all very, very important. Somebody asked earlier on the chat, and I just don't want to overlook this because I think we can start banding about terms that are not familiar. Moral distress, moral injury. Derek, is that something that you feel that has sort of arisen in the discussions about burnout? And even before this pandemic, everyone trying to get a better handle on what this means, yes, for doctors, nurses, but anyone else. And it's definitely arisen in this pandemic. Is that something you might be able to explain?
I'm not sure I can explain it, Madge,
Define
but
it.
I've seen it.
Yes. Yeah.
And I think when we place people in positions where they have to take moral and ethical decisions without a proper framework upon which to take those decisions, then we very often cause moral distress. And so it's our responsibility. Those decisions have to be taken by someone. And I think most people who enter the clinical domain understand that at some point they're going to have to take decisions that are difficult and potentially distressing. But it's our duty as leaders to give them the right kind of legal policy and ethical framework to make that decision making easier and to insulate them from some of the worst effects of that. And I added two things in the chat to Dawn's four, both of which I think can be helpful in the context of moral distress. Because if people can find meaning and purpose, if they're doing work that they believe to be meaningful, then it can just help mitigate some of the worst effects of moral distress. And if people find social connectedness, that they don't feel isolated, then again it can help. And moral distress, I think, can be diluted through social connectedness, through some sense of we're all in this together. I have somewhere where I can go. There's someone who I can talk to. I have a guide or a mentor that can help me take these kind of decisions.
Okay, thanks, Derek. And thank you, Jess Perlow from IHI, chatting in some of that concept of moral injury. I mean, it's big and heavy and sounds, of course, very deep, but partly one way you get at it is start talking about the disconnects. And I think that's come up in several comments and slides. Tyler, I think this is probably Tyler Norris from WellBeing Trust, probably a good moment because we're sort of, we just kind of jumped in, I guess, I don't know, the shallow end, or maybe we jumped into the deep end and now we're heading back to the shallow part. And for the time being, as soon as I guess we get back in pools and feel okay about that, talk a little bit about kind of what we're up to, IHI and WellBeing Trust, and thanks so much for your support for this.
First of all, Madge, thank you so much. This conversation is so rich, and like Don and Derek, I feel like, where do we even start? I'm thrilled that we have a series, and I want to just put a couple things on the table as we go forward. Just briefly on this moral injury, failing, distress. The healthcare sector and this country knows what dose-sufficient strategies to measurably improve population health looks like. This is not a failure of understanding the evidence base. It is a failure of leadership. And when we tinker as a healthcare sector, little grants, little project, do good things, when we know that it will not add up to population level impact, it is unethical. And so therefore, it is not surprising when people experience this moral distress because they're experiencing a response that is not rooted in what we are fully capable of. This healthcare sector in this country is capable of a next level of leadership that not only delivers the finest quality care in the world and takes care of its caregivers, but is actually creating a nation that is worthy of our mission. That is actually what we're going for here, that is possible for leadership. Now, I want to just pick up on the leadership of Providence, formerly Providence St. Joseph Health, in their leadership in helping found WellBeing Trust and making it possible for our national mission. But what we're doing in partnership with Prov around caregiver burnout and well-being. First of all, this must be a system-wide integrative approach to caregiver recovery and wellness. And at Prov, we've been facing it that way with both upstream and downstream interventions that we know are essentially necessary. This particular guide here is a stress meter, and you're going to learn more about this from Dr. Arpan Wagre, our Chief Medical Officer and a leader at Prov in the coming sessions, which we're using right now with our 120,000 caregivers to both assess how people are doing, caregivers are actually doing, and then using our tools like peer-reviewed and user-rated Credible Mind, or the self-guided CBT therapy programs through Silver Crowd, or our Work to Be Well focusing with young people and their parents. These are evidence-based strategies increasingly being driven by AI that allow our caregiver assessments to point people towards the resources we need. That's the kind of on-the-ground leadership that Prov, that's been at the front line of this in Seattle, has been implementing to help set the pace, and why in partnership with Providence, we want to share learning and all that and engage thoughtfully with all of you here, and why we're thrilled to be part of this. So as part of that, the focus of this series is going to be on caring for caregivers, mental health and well-being. And we'll talk about broader issues, but we're going to hone in on caring for the caregivers broadly writ, not only in healthcare, but those others in our community. We're going to have a second call on June 26th before we officially launch the full series on July 2. There'll be 7 calls between then and early September. Well-known thinkers, innovators, collaborators in the space, and some bright spots and tools. You're going to find this actionable, tangible to the specifics that the chat person was writing to. And like Derek and others said, we hope that this is going to be a space that is not only restorative, but a generative conversation for participants, for all of us to come together and sort of build our bench. And in fact, help us get back on the right side of what we are capable of doing for not only our caregivers, but for our patients, for our members and the communities we serve, so that the healthcare leadership in the country is helping our mayors, our governors, our administration reinvent what we're capable of being. And the kind of things Don just talked about, you're spot on, Don. And I would also like to continue the conversation. I think every person in America needs that because we're all caregivers. Thank you.
All right. Thank you, Tyler Norris. Thank you, Nikki Lurie, who had to leave just a few minutes ago. Of course, thank you to Don Berwick and Derek Feely and our wonderful audience. A big shout out also to Jess Perlow behind the scenes there on chat, who's working very hard on workforce issues and designing this series with WellBeing Trust. So a big thank you to the foundation as well. And this has been great. We did speed through a lot of tough stuff, but we thank you for hanging in there. We've got that survey over there in the right-hand column of your screen. Just help us and go ahead if you want to tell us we weren't concrete enough just yet. That's okay. Whatever is on your mind, we need to get the feedback. Look for the archived edition of this show, which will be posted to IHI.org later today and no later than Monday. And we've got a great archive of programs. We've been at it every week here since the end of March, and we're very honored to be doing this. We're going to be back next Friday at 10 a.m. Eastern Time. And at this point, we're going to turn the spotlight a bit to the Age-Friendly Health Systems Initiative, older adults, and some of the remarkable ways that an action community of many systems around the country really took the opportunity of the pandemic to keep at it with best practices and better ways to do things and adapt good interventions for older patients during the pandemic. So look out for those details soon on IHI.org. It's my honor to host these programs, wishing everyone good health, wishing everyone equity for the Institute for Healthcare Improvement. I'm Madge Kaplan.